All right, thank you, everyone. First of all, we've got hundreds, literally hundreds of wonderful questions. What we've done over the last 10 minutes is group them according to category. And we'll try to address everyone's questions, but I'm not sure we're going to get around to everybody, so I do apologize in advance. And what we try to do is pick out or handpick and filter the more important questions that would benefit the general group. For those of you that did not get your question or do not get your questions answered by the end of this 1-hour session, please come up. Our panelists will stay up here and answer a few more questions to be able to meet those needs. That being said, we've got a lot of questions on cognitive therapy. Okay, it's one thing that is often not addressed in our clinical settings. So can you explain what cognitive therapy involves? Dr. Thakur?
Sure. So cognitive therapy is basically brain exercises, and this is commonly done by a speech therapist. And my patients do seem to have benefit, and our speech therapist will not only focus on recall, concentration, attention, visual spatial difficulties, and she gives homework. It's like going back to school. And these sessions are, can be quite intense for patients. And they often do have, recommendations for certain websites. I think luminosity.com is the most popular one that can also keep up the practice, because the sessions can range from, 6 to 8 weeks, maybe a couple times a week. And then you're on your own to keep it up, because just like exercise, if you don't maintain what you do, those gains are lost. So that's kind of how we focus on cognitive therapy. So it's like going back to school.
Taking that a step further, you mentioned things like lumosity, but are there other types of things you can do dietary-wise or other health changes that can be made, Dr. Jhaveri or Darlene, when it comes to improving cognition?
I think that the research doesn't show specifically supplements or anything that will dramatically improve cognition. I generally ask my patients to take fish oil because it has the DHA and EPA, which are very important anti-inflammatory markers and also help with brain function in general. And I generally like to give fish oil in a dose of approximately 1,000 to 2,000 milligrams once or twice a day, depending on their condition. I recommend that, for example, to help improve their brain function. Have there been any solid studies that show specifically for Parkinson's disease? I don't think those exist, but I think that. But I like to empirically give this to my patients.
Okay, and again, how much was that?
So it would be fish oil. Usually, and this is actually addressing a lot of the questions that came up. It would be fish oil approximately between 1,000 and 2,000 milligrams. And usually there will be a ratio of EPA and DHA, okay? And typically that ratio is usually 2 of EPA to 1 of DHA, so it'll be something like 650 of EPA and 350 of DHA, and there's some other omega-3s mixed in there. Typically, and there's been a question about the brands and what brands I recommend. I don't want to get into specific brands necessarily, just because that's kind of counterproductive a little bit. But because fish oil can be very expensive if you buy more expensive brands. So in general, I like to give that kind of dose.
Okay. Then to the neurotherapist, does exercise play a role when it comes to cognitive impairment?
Sure, absolutely. If we recall one of Christine's studies that she presented, it talked about walking, just simple walking 3 times a week, 45 minutes at a time. Patients who completed tests for cognition showed that they had improvements after they participated in the study, and that was 6 months. But I know Christine and I can both tell you that we often will train cognition with activity because we know that dual task is a problem for patients that do have Parkinson's. So we'll often train. Oh, sorry, guys. So we'll often train dual task activities because we do know that when we have patients not only do the exercise but train cognition at the same time, they can obviously get 2 things done at once. So oftentimes, yes, we have seen cognitive improvements, and patients will report that, and the testing that's done pre and post exercise certainly show changes in cognition as well.
Now that might be a good segue. And a lot of people who have cognitive impairment, they tend to also have sleep disorders. And with those sleep disorders, the cognition gets worse. So a lot of questions that you came through, I was quite surprised about the utility of things like certain supplements or teas, different types of tea, and what would be the best type to help some patients get to sleep better and stay asleep better. Darlene, do you have any recommendations?
No, I would recommend adequate sleep, whether you want to lose weight, control your diabetes, or anything. Adequate sleep is very, very important.
And Dr. Jhaveri?
I generally recommend for my patients who are having difficulty with sleep, sometimes valerian tea, that's Valerian, valerian tea. It can come as a tea and sometimes comes as a tincture, which is basically some drops that you can put into water and drink. Other alternatives are kava-based tea, and you can get kava as a tea or as an extract, Kava. Sometimes there are combination products that you can buy where that has more than one supplement to try to help with sleep. And you can find these in your local kind of health food store, Whole Foods, Sprouts, or if you have a local health food store, they'll carry them. Chamomile tea is also very important, and more important than just the teas is just a kind of, if you're having trouble with sleep, getting a routine going. So, for example, taking a very warm bath before you go to sleep at night, sometimes that will really help with kind of helping you fall asleep and stay asleep. So those are the kinds of approaches that I like to take.
Okay. What would constitute a good sleep hygiene?
I actually have a whole list of things that you should be doing, and perhaps maybe I can, instead of everyone furiously writing all this down, maybe we can get a handout out to someone. Maybe I can do that for a website. But basically, here are the few things that I really recommend to my patients. Increased exposure to bright light during the daytime, preferably in the morning. Establishing a daily activity routine that you do kind of the same things every day. Exercising, preferably in the morning rather than in the evening. Setting aside time for problem solving and making lists and things during the daytime. The warm bath that I mentioned. Doing some sort of relaxing activity before bedtime would help. Avoiding specifically caffeine, alcohol, nicotine, and exposure to bright light in the evening will help. Avoiding heavy meals about 3 hours prior to bedtime will help. No napping during the daytime, and no watching the clock at night. If you do wake up, that would be helpful. Avoiding noise and disturbances during the night, so your room should be kind of pitch black if you can get it that way. Not having any night lights would help. Avoiding excessive heat or cold in the bedroom. If you find yourself kind of awake in the middle of the night and you can't fall back asleep easily, don't stay in bed. I encourage you to get out of bed, maybe turn on a very dim light and do some reading, kind of some mundane, boring reading. And what that will do is that will actually make you start nodding off again, and at that point you close the book and you go back to your room and sleep, because your bed should be used specifically for sleep or sex. So that's what I recommend. No watching TV when you're in bed.
But that's when all the good shows are on. Okay. So you mentioned actually meals. So Darlene, a question here is, are 5 to 6 smaller meals better than 3 regular-sized meals?
It's really up to the individual what they prefer to do. I say it's up to you. But I've seen now more data come out that eating small meals throughout the day may be a better option.
Okay. Any issues when it comes to GMO-modified products?
I think that's a very hotly debated topic. GMO products probably has helped save certain parts of the world, such as I believe they have had GMO rice products help with vitamin A deficiencies, which is around the world. I work in Woodland, and from what I understand, one of my coworkers say, you know, Monsanto's in Woodland. Some of the people are real radicals. They burn down their lab. I would really encourage you to eat real foods. And a lot of people are moving toward organic foods, which are very, very pricey. I really feel it's better to eat the real foods than not eat them and try to buy organic, because organic is very expensive. It's better for you to eat spinach, which is not organic, than to not eat it at all. Because certain foods, there's, if you Google the Environmental Working Group, the Environmental Working Group has 15 groups of foods that have a lot of pesticides. For instance, spinach is one of them. But I recommend, they say, you know, better to eat organic spinach, but it's better to eat the regular spinach than not have any money and not eat the spinach at all. Am I making sense? Eat the real foods. Whether it's organic or not, if you can afford the organic, that's great. But it's going to be very, very expensive.
So you bring up a very good point. A lot of patients come to my clinic, and I'm sure Dr. Thakur, yours as well, asking about supplements. And you really have to have a trust fund to be able to purchase all the supplements that might be out there potentially helpful for patients with Parkinson's. So with limited resources, I mean financial resources, Dr. Jhaveri or Darlene, what cocktail would probably be most appropriate?
So the limited resources question is a good one because I totally agree. I sometimes give my patients, not just Parkinson's patients, but all patients with other problems, a cocktail. But generally, it is cost prohibitive for them to be on these things indefinitely. That being said, I think that if you have, for example, if you have constipation that's very debilitating, I generally recommend magnesium for my patients at the minimum. And magnesium tends not to be super expensive. I usually try to give magnesium citrate for constipation predominant issues. And I like to give the fish oil like I already spoke about. Then just taking a general multivitamin. And I think I want to leave it at just those three because if cost is not a factor, I sometimes recommend more, but it depends on their condition, and it's individualized, like I said. But I think that I would probably stick with those three to start with.
Dr. Thakur, are there any others that you've heard about in your clinic?
So unfortunately, the large trials with supplements dating back to the 80s have not been successful. This ranges from vitamin E was unsuccessful, coenzyme Q10 at high dosage, which is actually very expensive, and then creatine supplementations, which also can have effects on the kidney. So at this point, we do sometimes do routine screening tests. People who have fatigue problems, sleepiness, memory loss will check vitamin B12 levels, vitamin D. Vitamin D is currently the hot vitamin in medicine in general. We see studies in Parkinson's. If your levels are low, supplement could help with memory as well as aches and pains. So definitely, checking levels and seeing where you're at, and then supplement if the levels are low.
Can I add something? So I agree with the vitamin D supplementation. Just like to add that the range for therapeutic levels of vitamin D are very large. Between 30 and 100 is considered normal. Most of my patients are actually somewhere between 20 and 30. I like to see them somewhere closer to, between 50 and above if possible. And that's only accomplished with a little bit higher doses of vitamin D, specifically about 5,000 units once a day. Now you have to be careful and make sure that your kidney function is normal and speak with your doctor about before you take vitamin D to make sure that it doesn't interfere with anything else. But that's generally what I recommend. Like I said, I could recommend more if the cost wasn't an issue, but sometimes the cost becomes an issue.
There's been a lot of buzz recently about the use of coconut oil, 4 tablespoons specifically, or things such as cinnamon or turmeric. Can you guys comment on that?
So these are, small, kind of case studies and these sort of things looking both in Parkinson's and primarily Alzheimer's disease. with the coconut oil and the turmeric. And turmeric comes from, India, obviously, spicy foods of India, and have lots more turmeric, and there's a lower incidence of dementia there. Could this cross the lines with Parkinson's? And this is all to be determined as well. Is it bad for you? No, it's not. And often people like the taste of coconut oil. I don't personally, but cooking with coconut oil is harmless. And so, and as we're hearing, fats are good for you now. I mean, we like fats. We like whole milk over here. And so, coconut oil is fine. Turmeric's fine. If you like that flavor in your food, as I do, that's good. So no harm done there.
I'd like to add, if any of you subscribe to the University of California Wellness newsletter, their November issue, 2014, I just read it last night. What the headline is on coconut oil. In case you're interested, you may want to read it. Very interesting. They say if you like it, that's fine, but it's not something that they would recommend.
Okay.
For those people, coconut oil isn't terribly expensive, and for those of you that try to cook with it, heat does denature oil, so it may be better to actually take it raw. So putting it in salad dressing may be better than actually cooking with it. And I see Dr. Jhaveri nodding his head over here.
I totally agree with that. So you definitely change the inflammatory levels in any oil by cooking it. So there's only certain oils that should be like you should be using for like deep frying foods and stuff, such as grapeseed oil is probably more heat stable versus coconut oil is probably not so heat stable. So you want to make sure that you don't overcook it or overheat it.
Peanut oil has a very high heat point. Most of you know it's kind of dangerous when you heat if you cook your turkey in a deep fat fryer, you use peanut oil. You got to be really careful because peanut oil will not burn until it's hit a very, very high temperature. That's why they use it in fondues.
I find that peanut oil is generally more inflammatory also and tend to stay away from that if possible.
So we're going to shift gears actually from supplements and kind of get back to exercise over here. There are quite a few questions on, does exercise have a positive effect on dyskinesia or tremor?
So with that being the case, exercise, as we've seen, can calm the mind and thus result in tremor reduction. But in some cases, the stimulation of exercise can worsen tremor after the activity. So that's quite variable. But definitely in the overall long run, we see calming of the symptoms. Dyskinesia is a side effect from the Parkinson's medicine, carbidopa-levodopa. As the drug goes to its peak dose, it creates these excessive movements. Exercising, curtailing that, I haven't heard of anything other than if the exercises leads to dose reduction of the medicine. As we said before, exercise is like a medication. So if we're able to reduce our overall Parkinson's medications, thus with doing that, the dyskinesias can be less. Yeah.
You guys have any comments on that? Okay, I guess not. There's quite a few questions here when it comes to where'd it go? Oh, here it is. I have Parkinson's and I'm in a wheelchair. What types of exercise would be best for me?
In a wheelchair? Oh, sorry. Just moving. So there are some awesome pedal bikes that you can get online, $20, and you can put them on the ground in front of you, and then you can pedal. So don't pedal and kind of watch whatever's on TV. You want to really focus on your pedaling if you can, and really try and pedal hard. And, you can track your time and see how long can you pedal for, and track the time and try to increase that time every day. You can also do, maybe a few minutes in the morning, a few minutes in the afternoon, a few minutes at night. Other things, just trying to sit up tall in your wheelchair. There everyone goes. You can take soup cans and do arm exercises in your wheelchair. You can sit and move your legs so you can march in your wheelchair. You can kick your legs straight. The biggest thing is just not staying still. So if you can stand up out of your wheelchair, I am a huge proponent of getting up every hour. So if you're able to stand up, everyone should stand up every hour. You should not sit for more than 1 hour. So that's...
I'd like to add something. We also recommend some strength training. The NIH, they have, a whole bunch of NIHs. It's National Institute of Aging, and it's called Go for Life. They're free DVDs you can get with the government. There's no shipping and handling charge. If you Google it, it'll be NIA, National Institutes of Aging.gov. And the program is called Go for Life. You can get a free DVD. You can get as many DVDs as you want. And I know they also have things both in English and Spanish.
You can also consider doing chair yoga. So just while you're sitting in your wheelchair, you could do some gentle yoga. And you should probably watch a video on YouTube, or if you have a local community center where they offer yoga for seniors, you can attend that class, and the instructor should be able to modify the yoga for you while you're sitting in your wheelchair if possible.
So from that, 2 questions came up that were actually, quite prevalent in these questions that everyone gave me. Number 1, Christine, you mentioned about a pedaling type exercise. So are there pedalers out there that people can purchase?
There are. So you can look on Amazon, on Walmart.com. They have a really cheap little pedal bike for $20. So that's the one that we have in the clinic. And that just sits in front of your chair, so you don't have to transfer onto anything. If you are going to purchase a stationary bike, a recumbent bike is the better way to go. So that's the one that actually has the chair to sit on, so you don't have to try and climb up onto the upright seat.
Okay. And then the next question, actually, that Dr. Jhaveri brought up is, are there any community programs here locally, not within your medical center, but maybe outside the medical center, that patients with Parkinson's can attend?
Yeah, so there's more places than you guys might even imagine. Here in this community, Dr. Khandhar mentioned, we have a very Parkinson's-rich community. So there are senior centers that have a lot of classes. Christine and I have compiled a resource list that most of our patients get, from programs all the way to Davis, a tandem bicycling group, to Parkinson's dance, to Tai Chi, yoga, all different sorts. So if you're in question, certainly we've shared the list with Larry as well. So I'm sure that the PANC would be willing to share that with you all, that these are places that we've identified some of our patients go and are comfortable working with a patient who does have Parkinson's.
Is there a list or a place that patients can go to actually find this information?
So hopefully we'll get it on the PANC website. That would be awesome. Right now, there's not really anything specific. I know the NPF does have some by region. You can go in and look for exercise groups or classes by region. I don't know who verifies that information necessarily, but I certainly encourage you to contact your neurologist also, who could connect you with a PT and that might be aware of those community resources also. Or hopefully the neurologist may have the list as well.
I know my patients who work in Woodland informed me that the senior center has various exercise offered free to people that choose to go there. That would be a great option.
And that's true at almost every senior center, again, from Davis, Woodland, Roseville, Sacramento, Auburn. If they're not free, they're priced very reasonable for patients as well.
Okay, so this question has also come up quite a bit. What's the utility of acupuncture when it comes to Parkinson management?
So I do acupuncture in my clinic, and I'm not aware of any studies that show that acupuncture is effective for Parkinson's specifically. But in general, I would say that acupuncture would be helpful potentially in the non-neurologic kind of symptoms of Parkinson's. Pain, for example, is a big one. That if you have a lot of pain, then acupuncture can potentially play a role in helping you. Generally, it requires approximately 6 treatments of acupuncture on a week, like once a week for 6 weeks before you really notice any big difference. The downsides to acupuncture are mostly cost, and because most insurances don't cover acupuncture, cost can become a big problem. But I generally don't necessarily do acupuncture specifically for my patients with Parkinson's, but I do acupuncture specifically for pain issues and some non-neurological kind of manifestations of patient problems.
Dr. Thakur, are you aware of any studies that show that acupuncture helps Parkinson's symptoms?
Again, mostly what he had said, the aches and pains associated with Parkinson's. I'm not aware of any formal studies as far as I know, as far as reducing tremors or improving other motor symptoms, but from what I know, it's more the aches and pains, yeah.
So, shifting gears, a show of hands actually, how many of you with Parkinson's have actually seen a neurologist, or a movement disorder neurologist rather? So it's really the majority. How many of you have not? So there's a few of you. I want to pose this question to Dr. Thakur. Is there a place, a resource, maybe online, where patients who have been recently diagnosed or are seeking a second opinion that they can go to try to figure out who in their area treats Parkinson's disease?
Yeah, actually, the Michael J. Fox Foundation has a resource. Their website's very informative, and so not only do they have potential movement specialists in your area, I think you just place your zip code, and then also clinical trial finder where they can, look at your data and see if any research trials are available in your area. So I think that's an excellent resource, and they have an email updates on research studies. So I think that would be the top place that I would recommend. And I think PANC also on their website does refer to specialists as well. I'm not sure exactly, but I'm pretty sure that they have that too.
So actually the PANC does have a list of all the Northern California Parkinson disease centers, neurologists, specialists, and neurosurgeons.
Okay.
And all their contact information as well. Is that right, Marianne? Oh, okay. So I'm sorry. They have the link for the Michael J. Fox Foundation for the partners in PD. Okay. Dr. Thakur, there have been a lot of questions about why do I have Parkinson's disease? Some of which is, well, grandma had Parkinson's, what's my risk?
Oh, okay.
Or questions like, I got hit in my head when I was 6 years old. Did that play a factor in the genesis of my Parkinson's disease? Can you comment a little bit about what the current thought is about the genesis of Parkinson's?
So we all feel that the true cause of Parkinson's, we're not totally sure exactly what causes it. There's increased incidence in patients that are rural living, increased pesticide exposure, increased well water drinking, heavy metal exposure in these. And so with that being the case, a lot of people don't have those factors. They have relatives that had Parkinson's. And could it be a genetic issue, or could it be more of a genetic susceptibility based on exposure to these environmental factors? Yes, definitely that could play a role. But with the genetic-induced Parkinson's, it's probably 10% of the patients, and those are more of the younger onset patients, less than 50, with a positive family history, where classic Parkinson's usually happens in the early 60s or so. And so could it be both, genetics and environment? Yeah, that's what we think. Your genetic makeup may make you more susceptible to developing that. Head trauma is kind of one of these things that has been shown. Multiple head traumas may increase risk for dementia, as well as the NFL. There's a huge lawsuit going on with that. And Parkinson's has been kind of thrown in there, but head trauma incidents, childhood, one time, that's definitely not the case here. It's more probably multifactorial, both your genetics and environmental, except in the young onset case where people are developing symptoms in their 20s, 30s, or 40s. That probably has more of a genetic influence.
A couple of years ago, there was an article that was put out that talked about how manganese or certain heavy metals might potentially contribute to Parkinson's.
Yeah.
What do you tell your patients?
Yes, I mean, that is a factor, and those patients actually have classic findings on their MRI lighting up in the area of the basal ganglia, and potentially that exposure in these heavy metal plants does increase the risk. And so we always screen those patients, and the MRI is a marker, but we still do, treat them with the similar medications, so the treatment's not any different, yeah.
How much of your patient population may have heavy metal exposure?
I really don't see that many heavy metal workers with the manganese. I think that's more in the Midwest here. So I would say other heavy metals, obviously there's other things, but truly the only link that I know of is with the manganese as far as, yeah.
Okay.
Can I add something?
Please.
So it's interesting to hear Dr. Thakur talk about this because, when you think about heavy metal toxicity, you think about inflammation. So the way I think about it is, the way your body detoxifies from these metals is actually through your gastrointestinal system and your gut. And so it's very important to have the dietary component actually as part of your treatment, because it's very important to eat those vegetables that Darlene and I talked about earlier. Because if you have a healthy working gut, your ability to detoxify from some of these heavy metals might be important. It's very important to have a working gut in order to detoxify. Now, what role that detoxification can have in terms of treating Parkinson's is probably still in the thought process phase rather than even the research phase. So I think it's very important to lead a healthy lifestyle for that reason also.
So you bring up a wonderful point. A lot of our Parkinson patients are plagued by constipation. So what is a good cocktail for patients when it comes to constipative issues? You mentioned before magnesium citrate. I always tell my patients to take fiber and drink a lot of water. But are there any medications, Dr. Thakur, Dr. Jhaveri, or exercise? Would that be helpful when it comes to constipation?
Generally, polyethylene glycol or Miralax is something available over the counter that basically brings all the fluid into the gut and keeps everything moving. And using this, it's different than a traditional laxative, and this will potentially maintain your bowel movements. And doing this, daily can help. The bottle, I think, says no more than 2 weeks. But we often have our patients with chronic constipation on the Miralax, and I've seen the GI doctors prescribe their patients up to 3 to 4 scoops at times. I generally, go by the directions, but Miralax is definitely something that can be used, as well as fluids, fiber, exercise, again, helps constipation, so that's obviously important too.
The foods with a lot of fiber would be your beans. Beans have the greatest amount of fiber, and things like barley you might find helpful. Now, barley takes 90 minutes to cook.
Anything to add, therapists, when it comes to exercise and constipation?
Exercise definitely helps. Just getting out and moving is going to help your digestive system start to move. So again, getting up and walking, riding the bike, doing yoga, doing Tai Chi, just move, stretch.
Okay. A lot of our questions actually are medication related. I'm going to reserve some of them for our next speaker, which is after lunch, who's going to speak a lot on the medications and sort of surgical advancements when it comes to Parkinson's. But quite a few of them I can have Dr. Thakur actually address now. We've had a lot of questions about side effects of medications. One in particular is low blood pressure. How do we monitor that and how do we manage it?
So low blood pressure is a huge problem in Parkinson's. Not only does the disease cause it, the medications can cause it, as well as your cardiologist is prescribing medications that can contribute. And so the combination of meds really requires teamwork from your primary care doctor, your cardiologist, as well as your neurologist to develop the best cocktail of symptoms. And, if you're taken off of all your antihypertensive and you're still developing, orthostatic hypotension, which means your blood pressure dropping when you stand, measures non-pharmacologically to help with that is increased salt intake, if okay by your cardiologist. I even have patients take salt tablets that, runners or athletes will do. That's available at any sports store as well as online. Increase fluids again, that's important. Some of these drinks, sports drinks, Gatorade, the low sugar or diet drinks, especially low sugar, may have sodium in it, that can help. And then as well as pressure stockings, if you're wearing stockings in your legs, it drives the fluid back to your brain and heart and helps increase blood pressure. Stockings at least up to the knees, sometimes up to the belly. And then sleeping in an elevated position, if you have a hospital bed, or putting cement blocks or extra pillows. And then we have medications that actually drive the blood pressure up. This needs to be obviously monitored closely by your internist, neurologist, or cardiologist. And these medications include fludrocortisone, midodrine, and most recently a drug was approved called droxidopa. And so there's several options here. And then potentially reducing some of your Parkinson's meds. More the drugs called the dopamine agonists, which include Mirapex, Requip, they tend to drop blood pressure more often than levodopa or Sinemet, so potentially lowering those dosages or withdrawing them if they're causing problems with low blood pressure.
Thank you. We've also had quite a few questions on dyskinesia. Can you explain what dyskinesia is and how we would manage it?
So dyskinesia is a side effect from the medications, primarily levodopa or Sinemet. And basically you get this hyperactive movement, dance-like movements that can involve the head, the arms, the trunk. And the issue with this is it can be quite tricky to manage it, because if you reduce your overall Parkinson's medications, thus you're more off or more stiff and slow. So often patients prefer to be dyskinetic versus off meds, but these dyskinesias can lead to falls, problems with eating and these sort of things. And so how we manage that first, number one, we try to maybe use lower dosages and maybe more frequent throughout the day, so you're not getting a megadose in the morning, megadose at noon, kind of do a slower treatment response, more frequent. We also have medications that can combat the dyskinesias, or one medicine in particular that's called amantadine. I'm sure most people are familiar. This is a flu-like drug that was found to be beneficial in Parkinson's, and it can help block or reduce the dyskinesias. And then lastly, we have surgical therapy, which is the deep brain stimulation, which definitely can reduce meds and dramatically reduce the dyskinesias. So there's a lot of available therapies to help with that.
Our next question is actually going to be both for Dr. Thakur and our neurotherapist, is how do you all actually monitor disease progression? What are the measures that you use?
So it's funny, I see my patients out in the community and they come and see me. Instead of saying hi to me, they're tapping their fingers or doing this motion. And so all these little funny tests that we're doing, this is all part of what we call the UPDRS scale, or United Parkinson's Rating Scale. And we monitor disease progression based on the slowness that we see in movement. We watch how you walk and the stability, if you're using a cane or a walker, if you developed other progressive symptoms, dementia, these sort of things. And this is how we're seeing how people progress. And I mentioned before, I noticed the people who are active tend not to progress as quickly. They have more stability. They're not using walkers as early. And the issue is, there's other problems in Parkinson's. You have hip issues. You have orthopedic issues. So you are, battling several things with, age and Parkinson's. But that's the main type of thing we do to monitor when we see you in the clinic.
And how about the therapist? What types of tests do you guys perform in your clinic?
So for patients of Christine or mine, we have a pretty strict protocol, if you will, that patients, they know what they're going to be doing every time they see us so that we can assess how well they're walking, how strong they are, and their balance as well. So all of our patients are being looked at compared to normative data, essentially. So we're looking at any patient who does have Parkinson's compared to the normal world, and our goal is we want all of our patients with Parkinson's functioning at that level, at a normal level. So this is how we're tracking them, through looking at gait, strength, balance, and also identifying if they may need an assistive device through the score results. So over time, we're looking at these numbers, whether we've seen someone 2 weeks ago or it's been a year or 3 months. We're always looking at those numbers to give that feedback back to Dr. Khandhar or Dr. Thakur's therapist, so that the neurologists or movement disorder specialists know where our patients are in the progress. And hopefully they're not. Hopefully their numbers are stable. That's what we're really working for.
Now, it's not uncommon for patients in my clinic, when I examine them, for them to kind of show off and to not be actually reflective of what happens at home. And I would assume the same holds true for you guys in your clinics, too. So how can patients actually assess their own symptoms at home and bring that information to you?
So I think, quite honestly, and I might be speaking for Christine here out of turn, but I think that having a caregiver really is the biggest piece, because they'll tell us straight away, oh, no way, he does not walk like that at home. This is, he or she is constantly shuffling and, freezing or this or that. So having that caregiver there is huge. And I think our patients use like the sit to stand, for instance, getting up and down out of a chair, as a way to monitor themselves, or doing some of their balance exercises, standing with their eyes open or closed, or doing a Tai Chi movement. And they can say, hey, I did this better. I did 30 seconds today, or I did 50 up and down sit to stands instead of 20 a couple months ago. So there's plenty of tools. And it's simple, just getting up and down. And we love to have the caregivers there, too, to tell us the truth.
Or you can just see Dr. Thakur somewhere out on the streets of Sacramento and do this. So you meant, the three of you mentioned motor type assessments, but does that really give weight to quality of life? And are there any measures for quality of life?
Yeah, there's the Parkinson's disease quality of life measures that looks more into the non-motor as well as the motor symptoms. Non-motor symptoms, as I mentioned earlier, depression, anxiety, is the biggest impact on quality of life as well as disability. And so as far as tracking this, I think the neurologist or primary care doctor needs to inquire from both the patient and the caregiver, at least every 6 months or a year, what's going on non-motor-wise. Are we having depression? Are we seeing social withdrawal? Are we seeing less interest, lack of appetite? Because there's things we can intervene with these non-motor symptoms, as well as memory and cognitive changes, which go hand in hand with depression as well. Because potentially medications, antidepressants, counseling, all can help with these sort of other symptoms that are impairing quality of life.
Okay, did you guys have anything to add about that, or?
Can I add a corollary to that?
Please.
Just to treat anxiety and depression, the soft belly meditation technique that I taught, and other mind-body medicine techniques, such as, at the end of your day, writing in a journal every day, and writing about 3 things that are good in your life, and writing them down, or calling your loved one and telling them every night. I have one of my patients do this, actually. Have them call their loved one up, or if they live with someone, turn to them and tell them, these are the 3 things that I'm very thankful for in my life, to really look at the positives that are happening in your life. That can all help with depression. These are all mind-body medicine techniques that are non-medicine related things. Medicines always have side effects. Mind-body medicine techniques do not, and they can really help with anxiety and depression as well, is what I found in my practice.
So you guys bring us some interesting points, and I think a lot of questions also are asking about this too, is the whole social hindrance piece with Parkinson's disease. Many of our patients are apathetic, many of our patients are not motivated. So we have questions here, how do I calm my movements in social situations, or how do I motivate my loved one when it comes to Parkinson management and therapy? You guys have, I want to hear from the whole panel. You guys have any suggestions?
So that is one of the most troublesome things that we deal with on a daily basis, and the caregiver has, seeing their loved ones change right in front of them. They become this social, outgoing person to someone who doesn't want to leave the house. And I think a combination of all the things that have been mentioned, not just doing one of them. I mean, medications are never just the answer. I mean, everyone's looking for this happy pill. You take it, and then next thing you know, you're so much more driven, motivated. These medicines, like you said, have a lot of side effects, so they have their limitations. So you have to do that along with the mind-body technique, yoga, meditation, tai chi, as well as potentially psychotherapy and counseling, speaking to someone about your issues outside of the family, cognitive behavioral therapies to help your mood, and then lastly, again, exercise. Even though you don't feel like going to do that 30-minute, walk around the neighborhood where it's bright and sunny outside, that will make you feel better after you're done. And so I think the caregiver has to do their best to try to motivate their patients. And occasionally, medicines do have their role. We do sometimes use stimulants to give energy and these sort of things. But then again, they have their side effects.
What I feel is that caregivers often can get very frustrated if they can't motivate their loved one to do what's necessary to help them. But I think that rather than that, I think the real issue is that the patient, the person who's suffering, feels this sense of loss of control in their life. And so if their caretaker can help them by being supportive and being there for them and asking them, what do you want to do? In which way can I help you? And sometimes the answer may be, I don't know. And that's okay too. And just be there to listen and be supportive in that way. I think that the motivation has to come from the patient. So when patients come to see me in my clinic, I don't sit there and lecture them about what they should be doing. I ask them, where are you at with your problem today? Where are you at with your symptoms today? And what things do you want to accomplish in your health? And I'm here as a guide to help you when I need to step in. So similarly for the person who's taking care of the patient at home, they need to be there and support them in that fashion. And try not to be frustrated, although that's very difficult.
You guys have anything to add?
I definitely agree. I ask everyone, are you going out? Are you still doing the things you did before? And then just, letting them know, like, it's normal to feel a little bit down about everything because you're different. But really motivating them with all the research behind all the exercise and showing them, like, you can make a change, you can do it. And I tell everyone, you have to get up every day and move because that's what's going to help you keep moving tomorrow. So just moving is going to help you feel better and keep moving.
Darlene? They already said it all. Okay. So there's quite a few questions on different types of non-traditional exercise approaches, such as myofascial pain, or myofascial release, or massage therapy, or can I get a hot tub in order to, warm up my muscles, and will Kaiser pay for it?
That's a real question, actually.
It is. Yeah. It is. Again, I hear about it during Christmas time.
Yeah, of course. So there are a ton of alternative therapies out there. You will sometimes hear about the Alexander technique for patients with Parkinson's. You'll hear about this myofascial release, massage. And as therapists, we can tell you the research, unfortunately, isn't there for some of these alternative medicines. But we also heard that acupuncture is not really well supported in terms of the literature or the research. However, when you talk to people and listen to what patients are telling you, it may work for you. It has worked well for certain patients, but didn't for others. Unfortunately, some of these alternative therapies are not covered under your medical insurance. So again, unless you have a trust fund or you have a very, very big Christmas list, you may not have access to these things. But certainly, if it's something you're interested in, of course, try it. But alternative therapies like Tai Chi, Qigong, some of the Eastern philosophies certainly are studied well and well supported in the literature for Parkinson's patients to be doing a lot of good exercise.
Okay. I'm going to shift gears a little bit. There are quite a few questions on, have we seen an increased incidence of Parkinson's over the coming years? We're hearing about it a lot more now and people coming out of the woodwork. We have 500 people here today. So why would that be? And number two, why does it take so long for some patients to be diagnosed?
Okay, good questions there. Yes, I think the incidence of Parkinson's is increasing. Is this because of environmental exposures, or are we just diagnosing it more acutely here, where patients, in the past were left undiagnosed? They were just treated with their primary care doctor and not referred. So that's, an unclear answer to that question, because there's over 1 million, projected 1.5 million Parkinson's patients, in the near future in the United States, and this incidence is rising. There's a whole organic food movement going on, which, as you know, is quite expensive. Does this relate to any less pesticide exposure? This has not been proven. So how this can be changed, it's unclear, but definitely we're becoming either more well aware of the disease or the incidence is rising. As far as why is it difficult to diagnose, because the Parkinson's symptoms can change with time. So you see one practitioner initially, and you may have, maybe a slight tremor, more of a postural action tremor, and then you see another practitioner 6 months later, and then you start developing, the classic signs of Parkinson's, bradykinesia or slowness of movement, rigidity. And so it takes time for this disease to evolve and come out to the practitioner. Or could it be, the person you're seeing is not apt on gaining. And often Parkinson's is misdiagnosed initially. They say it's arthritis, you have essential tremors, or, it's just related to getting older. And so that's the case. And so sometimes it just takes time. And that being the case, we're looking at ways to potentially diagnose people earlier. There's a big study going on with the Michael J. Fox Foundation's looking at patients with preclinical symptoms, meaning loss of smell, REM behavior disorder where you're acting out dreams, unexplained depression, anxiety. And they're looking at these patients and seeing, is there something, a marker, particularly the REM behavior disorder, they have a subset. Could these patients have a marker, blood tests, spinal fluid imaging, that could diagnose the Parkinson's earlier? So the future is hopefully we will have better diagnostic markers other than the clinical exam, which is the gold standard at this time.
Are there any blood tests or imaging studies that patients can request or physicians can order when it comes to confirming a diagnosis?
Yeah, I mean, there is a scan out. It's called the DAT scan, and it's a nuclear SPECT imaging. It's actually been available in Europe for over 10 years now, and we've had it here in America for the last couple of years. And this study does help confirm, but like I mentioned before, the gold standard to really diagnose the disease is a clinical examination. This test is an additional tool, and oftentimes it's not needed. If you have the symptoms, why do you need a $3,000 test to confirm? But in some cases, it's helpful where there may be a medication that you can't stop, especially with psychiatric diseases, that you want to do the scan, or if they're planning for surgery to do the Parkinson's, you want to make sure they have true Parkinson's disease. Or again, if it's early on, potentially if you have this REM behavior disorder, they may do a DAT scan in the future early on to see but what do we do from there? How do we treat the Parkinson's? And that's the biggest question. And so this scan is available. It's safe. It's been used in Europe for many years, and it's about half a day, and it basically measures the activity of dopamine transport in your brain, and will confirm the disease, and it has a high sensitivity. But in a lot of cases, it's not necessary.
Some of the challenges to actually developing new therapeutic approaches to treating Parkinson's is this. Number one is that we're still not quite sure what are some of the pathological processes that cause all this dysfunction in the brain. We know it's Parkinson's, we know the dopamine's involved, we know that the dopamine pathways are affected, but what were all the events that led up to it? And that kind of gets back to the question of what causes Parkinson's and what are those processes that cause all these symptoms to occur. And because we still don't understand that piece of it, looking at a cure or looking at neuroprotective type agents is very challenging. The second thing is we don't have a biomarker for Parkinson's disease, which is really a research tool where patients will be monitored over time using some objective measure, some biomarker, like they may have for some other conditions. So that's always been the challenge for most neurological disorders. That being said, I have one last question, and again, I apologize if I didn't get to your question, but we will have the panelists stay up here during the lunch break, at least before we show the viewing of the PBS special, in order for you to be able to ask your burning question. So this last question is really the elephant in the room is, what is the latest when it comes to stem cell replacement? And I'm not going to answer that. I'm going to have Dr. Thakur answer that one.
Okay. So, I get this question quite often. Stem cell therapy has been tested in the past with Parkinson's. They've had fetal nigral stem cells implanted in brains of Parkinson's patients. And unfortunately, the outcomes didn't work out. They led to more dyskinesias, and patients need deep brain stimulation surgery to combat that, as well as the autopsy results of these patients, because obviously some of the past have led to seeing the Parkinson's pathology within the stem cell itself. And then you go online and you see all these stem cell clinics all over the country, all over the world, claiming that they can cure the Parkinson's disease. And the techniques of how they're delivering the stem cells vary from taking stem cells from your gut and injecting it in your arm, or some centers are actually doing, spinal taps and putting stem cells. But again, they're taking, stem cells from fat tissue, which doesn't really translate into, brain cells, because stem cells, won't convert or pass the blood-brain barrier. And stem cells aren't without risk, because they can, form tumor cells and, create other issues. And so currently, the Movement Disorder Society, as well as all the Parkinson's associations, are not recommending these clinics because there's no proof that they work and could cost a lot of money out of pocket, $15,000, $20,000, I've even heard $50,000. And then secondly, in the future, we're hoping that we'll maybe have better delivery techniques of these stem cells, maybe use different types of stem cells, more adult, more mature, and implant them in the brain. But at this time, it's not recommended.
So at this time, I really want to applaud our panelists over here. They've really taken some time to put together some wonderful information for you all. So thank you very much.